Hi, everyone. I'm Sangeetha Reddy. I'm an assistant professor in internal medicine and breast medical oncology at UT Southwestern Medical Center and the Simmons Comprehensive Cancer Center. I'm very excited today to share some of the change in landscape in the first-line metastatic triple-negative breast cancer setting, particularly in light of the recent FDA approval of an antibody-drug conjugate, Dato-DXd, in the setting. I'm joined by my colleague, Dr. Ahmed Elkhanany. If you can introduce yourself.
My name is Ahmed Elkhanany. I'm one of the assistant professor of medicine at Baylor College of Medicine, Houston, Texas. And I treat breast cancer specifically, and I'm excited to be here and have this conversation with you.
Yeah, I think it's timely, given the recent FDA approval, just to kind of set the landscape of how we're going to review some of the data and how it should fit and how we're practicing in both the academic and community setting. We've made significant advances across all three subtypes of breast cancer, but triple-negative breast cancer has really been, I think, a little more limited, where there's still a huge unmet area of need with poor survival, less than 2 years in our patients. With the PD-L1 positive patients, at least, we've made some headway with the KEYNOTE-355 study, where there has been an overall survival benefit when PD-1 was added to first-line standard chemotherapy. But in the patients who were not eligible for that trial because they were PD-L1 negative, and now in those that could not receive PD-1, PD-L1 due to toxicities, still we really haven't seen an overall survival benefit with upfront treatment. What's been your experience sort of in clinic and patients you're seeing in that IO ineligible metastatic subgroup in terms of outcomes and the challenges you've faced?
Yeah, well, I mean, you've summed it up beautifully. It is unfortunate that despite all the progress we think we have made in triple-negative breast cancer, when you zoom out and look at real-world data, as you beautifully put it, unfortunately, many patients, median overall survival remains roughly about 18 months. There is a chunk of patients, almost 50%, who do not live long enough to even receive a second-line setting from some of the Flatiron data sets. And when you think about it, it's kind of sad that we are with such a huge burden of disease, almost 50,000 patients a year with triple-negative breast cancer, and we're still limited. The PD-L1 positive population with the advent of immunotherapy in triple-negative breast cancer metastatic setting did give us some hope. But even in that setting, realistically speaking, the needle have moved a little bit, but it's really a tiny move in the large scheme of things. What is even worse is the PD-L1 negative population who do not have any biomarkers for. So their care has been really resolving around chemotherapy with objective responses and in the 40s to 50s, and median response rates usually median duration of response around usually 5 months, 6 months. And that's kind of what we see in the clinic. You start patients on chemotherapy, 6 months later, their disease is progressing, they're breaking through chemotherapy, you use another chemotherapy, and objective response is even lower. And I recall, a very sobering number from the ASCENT-01 trial, in which objective responses went down to almost 5% by the third line of chemotherapy. So clearly, chemotherapy is something that has been used for a long time, but we now need to find better alternatives. And that's where the Datopotamab Deruxtecan data have really give us this hope, in which at this point we're seeing an onslaught of beautiful agents that really are redefining the landscape across all of the biomarkers.
Yeah, completely agree. The Flatiron data is really interesting, that 50% of patients really didn't make it to second line of therapy. It's a little different than what I've noticed in my own practice, but I think there's a spectrum, right? From more academic centers, Flatiron data really represents more of what we treat in the United States. And even beyond a more community setting. So I think it's important to make sure we're extrapolating any of this data to the wider population of patients that are being treated. And completely agree about the point of, even in our PD-L1 positive patient population, these are not the long survival tails we see in some other types of cancer where IO has been truly transformative, of leading to durable cures and otherwise incurable disease. So we need to do better there. And I think what the trials we'll discuss don't even fully touch on, and where we'll have even more of a gap, is a lot of these patients now would have already received PD-1 in the localized curative intent setting, which was not the case when KEYNOTE-355 came out. So really a larger number of patients wouldn't be the appropriate as they were originally treated when it was approved even there. So I think we'll have a larger sum of patients in this PD-L1 negative or sort of equivalent based on prior treatment record. But yeah, with these antibody-drug conjugates, I think a lot of great data on how they're superior to standard first-line chemotherapy we've been using. So Dato-DXd you mentioned, right? TROP2 targeting ADC, TROP2 being expressed in 80% or so of breast cancers, with the DXd component as the drug with a 4-to-1 ratio of drug to antibody or so. The others in that setting, we have TROP2 ADC with Trodelvy or Sacituzumab. That's with the SN38 payload, a little bit of a higher drug to antibody ratio. And then in the background of this, not against TROP2, but we're very familiar, I think, with HER2-directed HER2 or T-DXd there with a similar payload. How do you think about, let's say, explaining to a community oncologist, where does Dato-DXd, which is probably the newest of these that we as a community have a little less familiarity with in terms of treating compared to the other two, how, from a mechanism standpoint, do you think of it in terms of the payload and target and thinking about the patient population?
You know, from a community standpoint, I think there is a couple of points that we can elaborate on. You know, we can go into efficacy in discussion, but one of the main things is, you know, this is a drug that now have demonstrated both PFS and OS, as well as data from this meeting on PFS too. So efficacy-wise, we have very comforting data that this is not just bringing another new drug into the mix, but that you can actually shift the treatment landscape and make these patients live longer, even after progression on the first line. And it's a very important piece of information as we're moving all of these very active agents earlier on. To specifically talk about the biology, I think a couple of points are very important that can distinguish Dato-DXd, Datopotamab from other ADCs. And first off, it's the stability of the linker. And I think that this is something that, you know, physicians will understand. When we look at these adverse events of some other ADCs that have linkers that get hydrolyzed within the bloodstream, leading to, you know, a higher average, payload that circulates in the blood opposed to the intratumoral payload, which can lead to some more toxicities, including obviously neutropenia, cytopenias that we have to deal with on a daily basis. And, you know, neutropenias are problematic, and these patients tend to do, you know, drastically, worse with full doses. And, you know, again, we have ways to counteract this, but this is something that is quite serious in the sense of, you know, you have to factor that against patients' ECOG. The other point remains also the, diarrhea, which is also, can be life-threatening and can be grade 3 and grade 4. On top of that, you have some polymorphisms that make some patients, specifically African-American population, again, for oncologists treated in the community, might be more susceptible to these neutropenias and diarrhea. Case in point, the UGT-A1A polymorphism, which is 12% in the population, or up to 25% in African Americans. So again, these are clinical pearls that we have learned with the Govitecan payloads. From a Dato payload, we don't have to worry about some of these issues. There are other issues to worry about, but the polymorphism, at least neutropenia concerns, I mean, there are some of these adverse events. But so I think this is an opportunity rather than a limitation, because we have more agents, we have more room to select these agents based on the patient tolerance, treatment intensity, and frequency, adverse effects, and an anticipated ECOG and response rate.
Yeah, I think we have two very good antibody-drug conjugates in this first-line setting, both TROP2-directed ADCs. You touched to some extent on the toxicities, which we can talk about a little bit later, again, more in detail on the toxicities and how we can manage and prevent them. But from an efficacy standpoint, and thinking through, where do these two fall in how we are selecting what to treat, again, purely from more the efficacy standpoint, it's looking at these trials, I think, is important, because there's a lot of similarities in how the trials were done, but also some differences, right? I mean, so largely looked at a similar population of locally unresectable or first-line metastatic IO ineligible TNBC. One of them with the Dato-DXd had a different set of primary endpoints. PFS, where we saw that benefit of about 5 months, almost to the 11-month point from a PFS with the ADC, but also similarly a 5-month or so overall survival benefit, 18.7 to 23.7 months, and that's with the TROPION-Breast02 trial. With ASCENT-03 with Sacituzumab, similarly see a PFS benefit in compared to standard of care chemotherapy and giving the ADC. Overall survival data still mature, but not yet, doesn't look to be significantly different, at what was previously reported. Some differences in the trial design, though. One, the comparator arms were a little bit different in the chemo backbones, with TB02 with the Dato-DXd, standard of care for physician's choice chemo taxanes, which is sort of common to both trials, but they also allowed eribulin, capecitabine, I think single agent carboplatin, which maybe we use a little less often. In the ASCENT-03 trial, the taxanes as well as carbogem sort of doublet. Your thoughts sort of on, I guess, design characteristics between the trials as well as efficacy differences that let you think of one ADC sort of versus another, knowing there's no direct cross-trial comparisons because they're two, separate trials that were done.
So, and because of what you mentioned, that's exactly why, taking numbers at face value would also be problematic across many trials. Patient population is different. I think there is also the time from, last therapy was also different between the two trials. And either the comparative arm on the ASCENT was mostly similar to what we have normally seen in the keynote regimen 355, slightly different. That reflects more of the international diversity and heterogeneity, really, of treatment in that first-line setting. And I honestly do not think that this in and of itself is something that takes away from the data that we're seeing, given the fact that most practices really refer to taxanes as usually as standardized as sort of a first-line setting. With that being said, I think that it is quite important to look at not just the absolute magnitude of benefit, but also the fact that we have an agent that managed to demonstrate an overall survival in the first line setting. Quite frankly, this is a very sick population, and I think overall survival, which was, I believe, dual endpoint, is something that we really should go back to and focus on. If you go to other subsets of breast cancer, overall survival played a major role in ER positive and selection of CDK4/6. In triple negative breast cancer, which are even sicker patients, than you expect actually for them to do worse. This is just a testimony to, you want to call it the intratumoral concentration of the drug or the speed by which, time to response have been achieved. But I think that this is something that when I talk to my patients and I tell them, I want to treat you with this agent, and then my patient will ask me, okay, what is that going to do for me? How am I going to get better? I'm like, you're going to have delayed time for the cancerous one, and you're going to live longer. So this is something that I find that it makes conversations with my patients very easy. And that also, the other thing that I would highlight is, the fact that most of the patients who, when offered, different ADCs, a lot of these patients are either new to infusional treatments or might have had different, oral medications, and it's been a long time since they've treatment. So infusion intensity and time toxicity is a real concern for patients. And this is the things that what actually matters to patients is what I focus on when I talk with them about these two trials. So I would think, and then going into the efficacy data specifically, 10.7 it's a pretty decent number for PD-L1 negative. And I think that this is, we hope to break that 1 year mark, right? And we hope we'll be able to see that eventually. However, in making these patients able to go 11 months without their disease progressing while giving them superior quality of life, I think that this is a very important point to make.
Yeah, as you mentioned, unique characteristics in some of the patients enrolled. The TB02 study did include some characteristics that potentially allowed for sicker patients. So it allowed patients that relapsed within 6 months, whereas ASCENT-03 really limited to, you had to be at least 6 months out before you can go on this therapy. In the end, I think it was balanced, and about 20% of patients were relapsed within a year, but TB02, most of those patients relapse within the first 6 months. So it's good to know if we're seeing patients in that setting, here's where we have clean data that this could be applicable to you in the setting, and we do see the PFS benefit across all subgroups. So I think that's comforting where we really don't have that data from ASCENT-03 in terms of Sacituzumab, Govitecan. I think there were some differences in PD-L1 positivity. 10% of the patients or so were PD-L1 positive. It's interesting, and you mentioned, international cohorts versus, U.S., Canada, Europe, sort of, which were all grouped together, because for, I think, a large majority of those patients, they were included because they didn't have access to PD-1, PD-L1. So I think it's important to keep all this in mind and thinking through who are the patients that are enrolling, how does this apply to any individual patient, that whoever isn't, looking to apply it to, how does it apply to their cohort of patients they see. But one other thing we haven't discussed, where I think it makes it a little tricky to sort of compare what may be superior or not, is difference in the crossover, right? So ASCENT-03 did allow crossover, and I think in some cases provided it. So I think a greater number of those patients that progressed on the chemo arm did ultimately go on to get a TROP2 ADC, whether provided by, I think from the trial standpoint, or by then it was already available in subsequent lines of therapy, which could limit ultimately an overall survival interpretation there. With TB02, that wasn't allowed. So I think it's a cleaner trial in terms of assessing what is the actual overall survival benefit of adding this drug compared to not adding this drug, but makes it a little tougher on, is this really a superior overall survival, whether you get it in the first line or get a TROP2 ADC in subsequent lines. And, in their subgroup analyses, it's the US, Europe, Canadian population where I think that's maybe where that overall survival benefit wasn't seen as much. Now, I think in the manuscript, some of it could be, there was some imbalance in the baseline characteristics there where the ADC arm maybe had some worse factors, such as a little bit more burden of disease, more liver, more CNS, that could have accounted for that. But part of it is also access. We have more access in some areas of the world, including here, to be getting subsequent ADCs. So I'm in my own mind, I think it's good to have that overall survival data when I'm thinking through which one may I go for first from an efficacy standpoint, but I'm not totally clear deep in my heart, is that the end all be all between these? But one thing that did stand out is there was a difference in overall response rates between the two trials. So whereas there was a doubling of overall response rate, I think, with TB02 with Dato-DXd, The responses were pretty similar in both arms with Sacituzumab in the I think high 40% or so. So the control arms kind of behave differently between the two trials, which is why we can't really do cross-trial comparisons. But in one case, there really wasn't an improvement in response rate, though there was in progression-free survival. In the other, there was. So in thinking, our discussions on first-line treatment, half the patients not making it to second line, the overall survival powered endpoint helps, but the overall response rate, I think, is important also, right? In thinking of, we really want to maximize that response earlier. So yeah, still trying to reconcile the different pieces of data here, with the PFS having somewhat similar ranges of benefit while having very different results in terms of overall response rates, with Dato-DXd showing that, and Sacituzumab maybe showing these PFS benefits, but without necessarily that. I'm not sure what necessarily explains that, but that's interesting.
Yeah, I think you raised two very good points. I would want to add one comment on the overall survival question, which I completely agree with you, and again, it muddied the data. But I was happy to see PFS2 during reviewed the abstract. I mean, when we have BFS2 that acts, remains superior, that this is not just a matter of, as you mentioned, it's not just a matter of crossover and lack of crossover. That is, so we're still seeing these patients do substantially better. Now, I mean, it's tricky because you're calculating BFS2, including the time from the BFS, which includes BFS from the first, treatment. So there's also some, survivor bias here. But we are seeing improvement in BFS2, which, some people have used as a surrogate for overall survival. So I think that I agree with you about the point in crossover, but it seems like we're getting some cleaner signals, as you mentioned, and I'm not sure if that played a part in getting the FDA approval, and just the data seems to be easier to kind of interpret and just kind of demonstrate.
Yeah, and we know, I focus a lot in the IO space, but we know these antibody-drug conjugates have multiple mechanisms of interacting with the immune microenvironment and immunomodulatory effects, which ultimately may be lending itself to these OS benefits we're seeing with this class of agents, more so than standard chemotherapy, where it's been a lot of PFS benefit, PFS benefit, PFS benefit, but not necessarily with that same magnitude of OS. So, the efficacy with some nuances between these is one thing, but you touched already on the toxicities, where they have very different toxicity profiles, with making this in some ways a case-by-case decision for any individual patient, right? With Sacituzumab having more the predominant neutropenias, including multiple episodes of severe febrile neutropenia and deaths in the ASCENT-03 trial, along with diarrhea. And with TB02, with Dato-DXd, we're seeing some more unique, stomatitis, eye-related toxicities. How do you go about balancing that in patient selection?
Yeah, I mean, quite honestly, I feel like we're making other subspecialties work a lot harder. From immunotherapy to ADCs, we're like bringing everybody on.
Team science.
I know. Again, I look at that as I wouldn't call it necessarily opportunity, but I would say it, a spectrum of options that I would choose the option that works best for the cancer while having the least side effects for the patient. So from a community standpoint, I put in my head, I treat breast cancer specifically, but I also, have a lot of my colleagues that we talk all the time. And I think, the last thing you want to do is to start a patient on a therapy and not having a clear plan for when things go south. So a lot of the physicians, have been slightly reluctant to incorporate, for example, some of the newer ADCs because of all of these, and that remind me of the earlier days of the immunotherapy and all of the adverse events of immunotherapy. But in reality, what we've seen is that the grades are different. So they're not all the same. There are some emerging side effects, but if you look at these side effects, at their severity and their impact on quality of life, things tend to, be a little bit more, less problematic than anticipated. So, for example, let's talk about the other ADC, the Govitecan-based ADC. Grade 3 and grade 4, we've seen, a good number of patients. I don't recall the exact number. I believe that sometimes they're up to 10%. And again, grade 3, grade 4 neutropenias are pretty problematic, and so much so that now their own label, many physicians will use growth factors, which in itself, historically we rarely use them in the metastatic setting, right? Now we're becoming more and more because we have an effective agent, and we need to have patients not become septic, and then you have a diarrhea, which really has also put few patients in the hospital. So these are legitimate chemotherapy-like adverse events. Although we're familiar with them, we know that they are toxic, and they come in high grade at a higher proportion. Datopotamab Deruxtecan has some unique adverse events. Thankfully, most of the grade 3s were much lower in incidence, but they are emergent and they are new. And I think the one that has been interesting to me the most would be the ocular, actually, adverse events, which made it to the label. Matter of fact, including all the intraocular pressure monitoring and slit lamp. Nothing that a good old optometrist that you will find in Walmart cannot take care of. However, these are new, venues for us, and we've seen more ocular adverse events with many of the newer agents, ADC and steroid agents. So I think that the oncologists are becoming more familiar. Most of these agents, have been, or most of the Datopotamab adverse events in the eye has not been significant, severe to qualify as a life-threatening or at a grade 3 or 4. Stomatitis has been an adverse event that we have seen as well. However, it has been, pretty much well mitigated with good old steroid rinses. Again, we're familiar with that with the Afinitor data. So in my practice, I had many patients on Dato, whether for the ER positive cohort or within clinical trial context. And my experience that it is a particularly well tolerated therapy compared to chemotherapy in general. And we've seen that when we looked at the patient-reported quality of life and patients, PROs, which are essentially point to a very similar tolerance pattern.
Yeah, and I think with these toxicities, a key is, prevent it before they develop it, which gets a little harder to chase after the fact and maintain their quality of life. And then you want to avoid having to delay therapy and whatnot. So I think with Sacituzumab, Govitecan, right, we've gotten from our earlier experience, not everyone, I think 2 different approaches of treat with the drug, see how they're tolerating, then potentially add growth factor. I think many of us also just preemptively add the growth factor after the day 8 dosing, just given the high incidence we're seeing, and an unnecessary serious complication if there really is febrile neutropenia.
So, and that actually brings an important point. When I talk to my patients, we have to also account for, not all side effects are the same, right? So I have alopecia, in HER2. I will not give it the same seriousness as the ILD, right? But it might be more common. So the reason I'm bringing that up is, when I talk to patients, I tell them a grade 3 neutropenia is problematic compared to, for example, a grade 3 diarrhea. They're both grade 3 and they're both getting back to you, but one of them can lead to sepsis and a 40% mortality rate. So it's the combination is bad. Correct.
I mean, if you develop both, which you can, right?
Correct.
If you're neutropenic and
Then
get, some
somebody really
infectious
didn't like-
colitis
yes.
or, whatever.
Yeah. And this is, so again, I think that, however, that drastic differences in side effect profile across these agents, just lends in, to patient selection. Most of these patients have already received prior chemotherapy. They've already have some existing maybe neutropenias or have very poor reserve. Maybe they just came out of some capecitabine a couple of years ago. They already have existing neuropathy and overall, just poor tolerance. I think these patients will likely do worse with, cytotoxicities and myelosuppression compared to others.
Yeah. And with, Dato-DXd, which we're spending a lot of time talking about, and I think partially because of the recent FDA approval and because as a field, we're a little less familiar with it. So I think it's important for us to, how do we minimize those toxicities? Like you said, just like with the IO, we had to get used to the IO toxicities. So with the ocular toxicities of dry eye being very common, the keratitis, I think using these eye drops, preservative-free eye drops, I think, multiple times a day, at least 4 times a day, if not more, a little burdensome, but limits and prevents these issues. Seeing the ophthalmologist or the local Walmart optometrist, I think of, do you have baseline issues? In the trials, it was a stricter, you need a baseline exam, and then, intermittently in practice, again, I think it could vary to some extent between mandating that baseline. If there really are delays in getting it, I don't hold the start until I get that exam, but I usually send them to a specialist early on in their treatment. Other approaches, from other physicians have been, if they're not having any baseline symptoms, you could probably just watch it. If they develop something, make sure to send them. I think depending on your level of comfort there, I'm curious what you do in terms of sending to ophthalmology or optometry.
We actually have in the Beacon order set, we built in, the ocular drops, and we built in, steroid mouthwash for
at least 4 times a day with those steroid mouthwashes also.
And we've had, based on the label, had a little bit of a patient handout that we also give to patients. Every drug we have has a little bit of tiny patient instructions. I don't see it have been an issue with my patients, and most of them are very appreciative, and they understand. You explain what to look for, what we're concerned about, and patients typically do it. When it comes to the eye exams, it does need a little bit of a discussion and making sure that the patients understand what to look for. Make sure that they use their the single use typically are the ones that are preservative free. Refresh eye drops, I like those are easy to get. And then, and then being able to, understand the symptoms of dry eye, how that develops, and also any visual changes or any headaches that they might develop. And, I think, again, we just got comfortable a little bit with chemotherapies. We give them a handout of chemotherapy. Hey, you're going to have that. But if you look at chemotherapies, they have a lot of adverse events. And we typically, paclitaxel has eye irritation all the time. So, but it's a thing that because of these are emergent adverse events and we don't know, how much, how the severity, we'd like to be a little bit extra cautious. But you're absolutely correct. Prevention is key in these agents. And, the other thing that I mentioned to my patient that, there is still some concerns of LFT elevation, some concerns of, myelosuppression is minimal. But other than that, we haven't really seen any substantial toxicity outside of those. Yeah.
And, as you, nicely laid out, the patient education is an important part of that prevention, right? Because if they're not informed about these more unique or toxicities, maybe they haven't already been aware of, we can provide, we may know how to handle it, but for them to understand the importance of it, I think it's critical. I mean, when we initially started the trials, with Dato-DXd, where we ran into issues with patients is when they were not fully compliant with, the mouthwashes and the eye drops. Once we understood really the critical relevance of that so that we can overemphasize this to the patients, it stopped being a problem. So I think having them as part of the team is important. It was similar with T-DXd, right? With the ILD risk, we saw a much initially higher risk of toxicities and even mortality with the initial reports that came out. But as a community, both as the physicians became more aware and counseling the patients to let us know if you have a cough, if you have shortness of breath, it, I think, improved and really reduced the severity of it. But to that point, this is Dato-DXd is another DXd-based ADC where it's also important to counsel them, to let us know about those same symptoms, but the incidence of severity seems to be in a different scope than T-DXd, where we're not doing the same magnitude of monitoring that we really require in a lot of our patients on T-DXd, right? Where every 6 to 9 weeks CT scans, because we do see some of these severe hospitalizations and mortalities every now and then from this drug. But with Dato, it seems to be a little bit of a different beast. I think 3% or so, I think, on the trial had ILD. There was one death, and this is, in a 600 patient or so trial where half were on the ADC arm, but ultimately, I think there were other factors in that patient related to disease, et cetera. So I don't think they clearly labeled that as a treatment-related adverse event attributed to the Dato, though, I mean, the ILD was probably from the Dato itself, but the death may not necessarily have been that. How have you been counseling your patient with that? And have you been doing special monitoring outside of, the regularly frequent restaging scans to try to catch, any grade 1 asymptomatic ILD events?
Yeah, no, I agree with you. I mean, it is a risk. It is significantly lower risk at a 2%, and I think that don't go above and beyond when it comes to, telling them what to look for, because by that time, I want to be actually seeing it before they even report. So I explain to them, but my goal is to be able to see it at a grade 1 before they actually have any grade 2. I do, however, change my practice slightly. I've always been a PET-CT person. I love PET scans. They're just more sensitive. However, whenever I use an ADC now, I tend to begrudgingly use more CAT scans. I think CAT scans, especially contrasted CTs for staging, is pretty standard. Non-con CT scans are a very low threshold for me with any of these agents. Whenever any patient reports any incidental adverse event. A lot of these trials have excluded patients with lung diseases and existing, lung, problems. And, I think that is a limitation. And because in real world, you get what you get, COPD coming in through the door, chronic bronchitis, they're coming in coughing their hearts out. So what am I going to do for these patients? So I think that being vigilant and, having low threshold for scans remain the standard across any of these ADCs. We actually see that even across non-Deruxtecan ADCs as well. I mean, the entire TOP1 isomerase class has risk of pneumonitis, so I've been just more vigilant. But as you mentioned, thankfully, and as we are getting more, primed to pause and throw steroids at a low suspicion of a grade 1, I think we're seeing less and less of that becoming a problem.
Yeah, I am not, I get PET CTs. I stick with the CTs more often in a lot of my patients, but I think that's important to point out when concerned about the lung. The CT component of a PET scan is not as high resolution as a traditional CT scan.
Correct.
And further, a high-res CT, even higher resolution. So yeah, so I use the standard CT chest, abdomen, pelvis, and bone scan intermittently when I'm restaging in these patients. But if a patient comes in with a symptom that's concerning for ILD, I'll usually order a high-res CT also to further really look into it, because sometimes I'll find things on the high-resolution CT that I might not necessarily, even on a regular CT scan. Or
non-con. I mean, that's I think a good important reminder that non-contrast is really what you want to look for. I mean, high resolution CTs are obviously non-contrasted. So this is an, if you are having this particular doubt, I think that's important to kind of remember.
So we have two good TROP2 ADCs in this setting. We can keep discussing, which is the better to use in the first line. Again, some have more mature survival data, cleaner data set, better response rate. But in the end, we still have two. How do you think about utilizing both of these? Now, putting HER2-directed ADC to the side. So we have both. Would you sequence these one after another? If you treated with Dato-DXd first, at some point, would you use, Sacituzumab, Govitecan, or if in a patient you felt Sacituzumab, Govitecan is more appropriate based on the toxicity profile and preferences of the patient or whatever you're considering, would you subsequently treat with Dato-DXd?
I don't know.
Can you solve the big question in oncology right now on sequencing
like
right here and now?
Good plenary talk for ASCO when the results come out. I think that, first off, there are many active trials that are looking at sequencing right now. So we are going to have this answer in a clearer fashion, hopefully within the next year or so. We don't have many data on sequencing. We had actually a recent trial in ESMO Breast, the SATIN trial, very different patient population, HER2 positive, to the negative trial with a Trodelvy with Herceptin post in HER2. We also have data from the pan, tropion pan tumors. So the across the I think pan cancer, and there was some data on some sequencing of ADCs. In general, and if you look at all these combined, it appears to be some efficacy on ADC sequencing, but the number and the mechanism of these are differ by the different classes. I think there is also another point in which we don't even necessarily know what are the most impactful reasons for resistance to ADC1 before going into an ADC2. So you'll look at a classic HER2 targeted in HER2. Some would say it's the payload, active efflux, and some would say just the downregulation of the target. You have similar discussion in the in the TROP2 world, but to even make it more complicated, Trodelvy or Sacituzumab, for example, we know that it's TROP2 independent. Datopotamab is not necessarily dependent activity-wise on the ligand, on the TROP2 expression. So all of that collectively just paints a picture that we don't know necessarily how much activity to anticipate after progression on one ADC. And that would be even more important if we have TROP1-directed resistance, like an upregulation of ABC bump, there is efflux in the drug. So to answer your question, I don't know what the data will look like. I think it is a reasonable approach. At the end of the day, we will likely use some sort of a chemotherapy anyways. And we know ADCs have been historically outperforming chemotherapy at every step of the way. Some physicians are advocating a sandwich approach, do an ADC, give some chemo break, maybe a different mechanism, not a TROP1-directed mechanism of action, and then go back to another ADC. That's also a possibility. I think that this was going to be a very important question. I think in reality, people will sequence ADCs, and we're going to actually have some real-world evidence before we see it in a randomized trial fashion, to be honest, because they are much more tolerable on average compared to chemotherapy. So that's something that I believe is going to happen. One point on ADC sequencing that is also important to consider is the role of immunotherapy in these settings. And if somebody received immunotherapy in the first line setting, do we continue immunotherapy in the second line setting? There are trials that are also asking this, and one of the TBCRC trials, 047, is looking at different combinations with Sacituzumab, Govitecan. So again, it's a very active field. I don't think there's any clear data on that topic, but I think that from a practical standpoint, patients will ask about it, and we might end up having to have some of that in the real-time setting. So.
Yeah, I think, the proper randomized trials that'll better answer this, and even the real world data in the meantime will be critical, because this has been an issue even before we added Dato-DXd to the mix, even just with, Sacituzumab and TDXd to this. There is some data, with the initial Dato-DXd data that came out because Sacituzumab was out before then. So they did show some responses in patients that previously received Sacituzumab, being followed, I don't know if immediately or with some gap, by another TROP2-directed ADC with Dato-DXd. And some of these patients did respond. I mean, it's not the response rate you'd expect in an untreated population, like we're talking about with these trials today. So yeah, I think it's who are the patients that are likely to benefit? What are the resistance mechanisms? Is it the target? Is it the payload? Can some of those resistance mechanisms improve over time so you can do a sandwich approach? I so far have been adopting the sandwich approach, and then at least prior to Dato-DXd entering this mix, with TDXd, different payload, different target. I've been using that approach. Now it gets a little more complicated on, now out of these 3 ADCs, how are you going to potentially sequence them in a background of chemotherapies that as a class are inferior to these, but maybe different from a payload equivalent standpoint. So yeah, something for us to stay tuned and continue anecdotally in the meantime, but using any real world data when we can. And beyond these, I think it's also other sort of data we're eagerly awaiting is other combination related studies or looking in different settings, right? So we talked about the first line metastatic untreated IO, ineligible triple negative breast cancer population, but we have TB05 in the PD-L1 positive setting, similar to ASCENT-04. Can you combine this with a PD-1 or PD-L1 with, in the case here with durvalumab, to see, do we similarly get an overall survival benefit, PFS benefit in that setting? What about in the neoadjuvant and adjuvant localized setting? When we see improvements in the metastatic, we always move it to the curative intent setting. I think that trial has finished accruing and enrolling, and we're have a while's away to wait for a readout, but can we move these all earlier? And how will that ultimately, affect our sequencing down the line? A lot of moving parts in the breast cancer space, which is exciting for our patients, but we'll need to continue strategically seeing, how do we put these all together to offer the best treatment sort of lines for our patient across their whole continuum.
We have data on the Begonia trial, which were actually very promising in the combination. We see patients with PD-L1 tend to do, overall on average slightly better. So maybe that would be the impetus for us to cross a BFS that beyond 1 year. And, I think that, it's a testimony, however, to the fact that we still don't understand really a lot even about, the efficacy of immunotherapy, specifically with the ADC combinations. I think to this day, we still even ask the same question: who is benefiting from immunotherapy really? It's not, PD-L1 is only part of the equation, but we know that there are other markers, TNBC being a classic one, but there's a lot more, TCR and all of these kind of converge into what you said. Can we start personalizing more and more, not just from a molecular standpoint, but also now we have multiple agents of multiple toxicity spectra, and with different prior exposure profiles. So it's certainly getting more challenging, but it's also getting more rewarding to really navigate all of that options spectrum to the patients.
And with PD-L1, as well as other IO markers in the IO space, these are all very dynamic. Unlike maybe TMB, you could have a PD-L1 negative environment one day, receive another treatment that converts it to an inflamed PD-L1 positive, I think, as standard, we haven't incorporated as much of these on-treatment biopsies. We have been doing, with ctDNA, but less so in the tissue, which I think is more critical from an IO standpoint, where looking at 2 weeks, looking at 4 weeks, it may change. When you give the ADC, if that's modulating the immune microenvironment,
Have you seen an IO switch like this, like PD-L1 that converts on repeat biopsies from a negative or CPS score to a positive score?
I don't know if strictly the CPS score, but in other research studies I've done in the melanoma, let's say, setting with neoadjuvant immune checkpoint blockade, on-treatment biopsies better predict, sort of responses to these therapies compared to pre-treatment, because you can get changes in the immune infiltration. True. You're getting a pharmacodynamic response, right? Instead of just waiting for the ultimate imaging response. So it'll be interesting to see how the field evolves there as we're combining all these therapies. But to kind of wrap up what we're doing and conclude, I wanted to ask, what are your take-home points in sort of a couple of areas? One, more broadly, we're talking about ADCs in the first-line setting, which is very different than what our standard has been of chemotherapy. Is there a role to consider chemotherapy in the setting anymore in the first-line setting? And if not, or if minimally, it has a role, what do you think are the hesitations for the greater community and from the community practice standpoint in making that switch? And then two, with these, these two now NCCN1 recommended TROP2 ADCs and the recent FDA approval and the setting also of a co-primary overall survival endpoint that was met, how do you see that changing our landscape in the coming months, and any other final sort of take-home thoughts from your end?
Yeah, no, I think it's exciting time. I think that there will always be a role of chemotherapy because you still want to navigate, the best treatment for your patients. I think the role for chemotherapy is decreasing every day. I would still think of that 95-year-old patient who comes to me with an oligomet or a pulmonary nodule and her 7 family members sitting in the same room. I still think of probably a low dose, maybe capecitabine or, little tiny smudge of paclitaxel might be a good option for these patients. However, I think that for the majority of patients, we have to be very clear on the fact that at every single point, with very few exceptions, antibody-drug conjugates have outperformed chemotherapy. And to continue giving chemotherapy to these patients, especially for those who are of good performance status and no significant comorbidities, is a disservice to their disease when we specifically talk about such a rapidly developing, rapidly progressing disease like triple-negative metastatic breast cancer. So for the majority of my clinic patients, I would use ADC, antibody-drug conjugates, instead of chemotherapy whenever I have that option. Prior to the FDA approval, we have many clinical trials, so I would do the best I can to put these patients in trials because I know that they are getting the better treatment. For the take-home message when it comes to the NCCN guidelines interpretation, I again take that as an opportunity rather than a limitation. We have 2 very distinct drugs. One has every 3-week administration, overall survival, BFS survival benefit, with some ocular toxicity and some mucositis toxicity. We have a different ADC that is very familiar to the TNBC setting. However, with well-documented neutropenia and diarrhea concerns, as well as 2 out of 3-week infusion. So I'm not saying that one is better than the other, and we don't have these data. We're never probably going to have these data. However, one is definitely different from the other, and each patient is different. And then being able to kind of see how this would work out in real life is probably important. I would, however, argue that put in my patient advocate hat. When patients are presented, patients will want to go on a treatment that will reduce their time toxicity and that will make them live longer. So I think that these are important points to consider. And then I think that regardless of whatever agent patients are in, we now have to be very comfortable with extending that patient education session a little bit longer. There's a lot of printed material on the official websites of these agents, on the on-label FDA about patient instructions. We have resources like ChemoCare. I think it's important to provide patients with the right amount of information to avoid problems and high-grade toxicities that come down the line because we just did not intervene proactively, as you mentioned earlier on.
I think that was an excellent summary. I agree with you on actually all the points that you made. And I'm hoping this was a useful discussion for our audience members as well on discussing sort of the most updated data in this setting, looking at these two ADCs, and again, with sort of an initial overall survival benefit that hasn't been a typical co-primary endpoint in our trials, but probably should pave the way for how we do future studies as well, right? Since that's ultimately what's most meaningful for our patients, the increased response rate, and discussing some of the unique variables that will factor into which patient may be appropriate for certain treatments in this first-line metastatic IO ineligible setting, while balancing how do we mitigate those toxicities to make sure we can deliver the maximal benefit for them without shortchanging their ability to get the treatment or putting them into trouble, I think is important. A lot of advances we've made here, which is exciting, but still a lot more to go. So hopefully these upcoming trials on looking at sequencing, combinations with IO, moving into the earlier curative intent setting, which may actually have the most impact, will be great. So thank you for this discussion. This was great to talk through all this data. And
absolutely. Thank you so much.
Thank you to anyone listening.
Thank you all.